Let me welcome Dr. Greenwood for a keynote speech, and then we proceed from there. Thank you.
Good morning. It is my honor to be here giving the keynote speech for the research and development session here at WHSS. So I just want to put us on a positive note to get started on the panel. Across the world, the public interest in research is growing. UNESCO recently put out a report and showed that the investment in research in low and middle income countries is actually representing a larger portion of total research spend. So between 2007 and 2013, low and middle income countries actually represented 20 up to 30% of total research spend. And finally, when we look at authors of publications over that same time period, publications with African authors increased by 60%, and publications with authors from Arab states increased by 110%. So there really is some positive forward motion going, and a conference like this that brings students together to talk about research and development early on in their careers is another really positive movement. So with that, I think we'll get started with the panel.
Long time ago, research and development happened at different levels, like developing drugs we are using, making sure they are developed and they are efficient and safe. You know, different clinical trials those medicines should pass through in order to get to the market. You know, even in the market, they should undergo what we call pharmacovigilance phase, where you are sure that they are still safe. And still, research continues either to improve pharmacokinetics part of those drugs, make them efficient as fast as you can, make them less harmful, etc. So all those activities aiming at improving either process or new products or improving existing products are known as research and development.
I want to give you two examples of Rwanda research and public interventions. One in my area. We have in Rwanda two principles to articulate our way to deliver care. One is the geographical accessibility. We want every single Rwandan to access health care. Then about geography, how do we go around the hills? Build hospital infrastructures. We have 7 referral hospitals, 4 provincial hospitals, 37 district hospitals, over 500 health centers. We're building over 1,000 health posts, and we have an army of community health workers, 45,000. All those to make sure that whenever a Rwandese needs care, can access it in terms of geography. The second principle, we want our healthcare to be affordable. Then we talk about mutuelle de santé, health insurances. So when I see geography, by now, a Rwandan walks 51.2 minutes to access by foot a health center, which is very important in terms of accessibility. So when you see in public health improving, it is not just around improvement. It is around thinking through data, around thinking through works, around thinking through the pain the population is going through so that we can make a decision which is ground-based.
You know, there are certain areas that I have also focused on artificial intelligence, machine learning, and how to make robotic surgery, I'll call it democratize it, we know in the US, the cost of robotic, robots are exceptionally high, and they're only accessible in big hospitals. The question is that if we can implement machine learning, artificial intelligence, where even we can bring the cost of robots down and being able to really understand the robot sensing the presence of nerves and avoid unintended damage to nerves, that really will end up decreasing the cost of surgical outcomes. What I also think about interventions, in terms of research, is really think about smart devices and incorporating those in our daily lives, and how that information that we gather from smart devices can help us to intervene.
Joy of knowing. We've collected data and now we have data, so we know the data. And so coming back to Dr. Bonnie, how do you use the data that we have in relation to quality improvement in healthcare delivery? How do you use this data to try to improve patient care?
So in regards to this question, I think part of it is setting goals and measures. And so even when we look at the SDGs, you have the goal, and then you have the target indicators that will tell you that you are on your way to achieving that goal or not. So it's important to set goals and then use that data to know, again, whether or not you're on the way to getting there. In my experience, quality improvement research is hugely valuable because we may think that we're implementing an intervention that will have a positive outcome or that we're implementing it appropriately. But without systematically evaluating what that implementation effort does, we may not actually be having the impact that we're looking to have. One example that stands out to me is the WHO Surgical Safety Checklist. And that was developed and showed incredibly wonderful outcomes in regards to mortality reduction after surgery. And institutions that implemented it saw good outcomes, but over time, it came to attention that maybe everybody wasn't consistently implementing it in the same way or completely, and perhaps that the outcomes being achieved were not as good as they could be, or potentially they could actually be causing worse outcomes because a checklist may give you a sense of complacency that, oh, if I check a box, I'm doing a good thing, but maybe I've skipped some steps.
We identified a challenge that among healthcare professionals, mostly young professionals, they lacked basic research skills. So that motivated us to start up research courses to teach young professionals how to do research. But we have challenges. The challenges are, number one, we lack facilitators. How do we get facilitators, academics, to be interested in translating their knowledge on research to young professionals? How do we make tangible researches? How do we get our universities to support tangible researches by young students? Not necessarily what will make some lecturers get their degrees, PhDs, but something that will improve the capacity of people in Africa.
Now, we have to start on a small scale. You can't expect everyone to jump on the bandwagon initially. But once they start seeing fruits of the effort, they will jump on it. We are here to do good and impact lives. That's all life is all about. So that would be my first one. Second, I think it's going to be part of the subsequent discussion on gaps in research in Africa. How do we change that? And I heard yesterday about forming what I call the research clusters. There is no way every institution can have expensive instrumentation. We talked about exchange rate. We talk about who controls the exchange. There's a limited amount. A lot of the technologies are developed overseas. There's not enough money to go around to buy MRI or a large NMR for every university. But if we establish a research cluster with dedicated area of focus, maybe in orthopedic research, maybe in biomaterials, maybe, but now bring interdisciplinary team to work together as a team. We'll be able to really significantly advance the science in this area. So I know I'm really passionate about industrial research, but also more academic research because it's dear to my heart. But more also is Africa is dear to my heart.
Stem cells have the capacity to dictate, to reprogram the environment to better its own environment. It can reinvent itself wherever it is. It has the capacity to self-renew. It has the capacity to do what it wants to do. It has the capacity to differentiate in anything it wants to be according to its own environment. You want to have an impact, you have to assess your environment. You have to study your environment. You have to research your environment. You have to research your country, your nation, the needs, and then reprogram. And you reprogram in terms of leadership. And I'm going to give you 4 dimensions of a good leadership. First, you have to have a vision. Second, you have to have provisions for your vision. Third, you have to be able to predict. And if you can predict, you can prevent. In terms of research and maternal child health, Rwanda has made milestones. But we know we still have a lot to do. Even though we still have a lot to do, we say the focus on the mother and the child comes not from research, it comes from our culture. We say that the mother is the heart of the household. If the heart ceases to beat, then your whole household falls apart.
I would love to be with you in person. It's a matter of great regret that I cannot be. But this is a most important gathering. In thinking about how to improve the health of the populations we serve, it's obviously of vital importance to consider not only health care, but the determinants of health. What leads people to get sick in the first place? And health professionals clearly have an important role to play. And if people get sick at a higher rate than others, through no fault of their own, but because of the conditions in which they are born, grow, live, work, and age, and because of inequities in power, money, and resources, that's unjust. And that's why we put on the cover of the WHO Commission on Social Determinants of Health, social injustice is killing on a grand scale. I invite all of you to join the social movement for health equity, not only to be treating people when they get sick, but to be addressing the conditions that made them sick in the first place. And that means social determinants of health in order to achieve health equity, a fairer distribution of health for everyone globally.
But there remain many challenges, not just for Rwanda, but particularly for many African countries. And I will list just a few as I wind up my short talk. First is demography. And the good news is that we are living longer, all of us. Our life expectancy ever since people are getting treatment for HIV is moving from the 40s to the 60s. So people are living to 60 years and beyond. And that's good news. The bad news is that as you turn 60, as I am turning soon, you start getting diseases you would not have got if you had died earlier. Start getting non-communicable diseases, you get diabetes and hypertension and cancer and other diseases. which means that the health system has got to adapt to the fact that demography is leading to a different and bigger burden of disease. Demography often means urbanization as well, and more people are living in cities. Kigali is one of the fastest growing cities in Africa. And urbanization comes with its own diseases of pollution, of stress, and other negative side effects of living in the city, which I don't see now when I live in the village of Rinkwafu.
If you can manage to bring antipyretics in the community, now the Ministry of Health is starting to bring palliative care into the community. So we need to see how the community acts as an actor in the service delivery and make sure that we together design strategies that will cut on the cost but will not compromise on the quality. It's important that in every initiative that we propose, we as all potential patients and all healthcare providers, we look into, we check ourselves for quality, but then we don't shy out to make sure that the smallest or the furthest person in our country is actually accessing care without the burden.
The cost of healthcare on average in Europe would be range between $3,000 and $5,000 per person per year. In Africa, put that at $110. 110 compare with 5,000 and 9,000. So we cannot follow the route of Europe and North America. So we have to find a different way out of this cycle, because if we go that way, we will never afford it. So the simple question is unaffordable. So the only way to actually reduce the cost of chronic care is to build a strong primary healthcare system and create a prevention mechanism. That is the best way to do it. And the governments in Africa need to invest so much in prevention, because if they don't, then they'll have to face the burden of care that you're talking about. So for me, it's about all these things that Rwanda is doing, lifestyle. It's about what South Africa is doing. They recently introduced a tax on sugar, 20% tax on sugar, and they're discussing now ring-fencing that to preventing chronic diseases. It's about these things, and that is where the government needs to invest. Other than that, we'll have to wait, as I said earlier, and invest in tertiary and secondary care and wait for all the people to come, and then the entire healthcare system will burst. So reprioritize our funding for healthcare from secondary and tertiary and take it down to primary healthcare so that we avoid the coming catastrophe.
Universal health coverage is a very powerful concept that public health needs to offer. Because for me, I look at it as a full and inclusive. So we need to ensure its quality, its efficiency, the equity. And then universal health coverage is a journey, is not an ended goal. So, and therefore, all countries must take actions to accelerate progress towards that goal.
You know, we've kind of touched on some of this already. You know, we play at teaching professionalism and ethics. You know, what does it mean to be a professional? Because footballers are professionals, and yet their behavior is a little bit different from the kind of behavior you'd expect from doctors going around kicking things and spitting on the floor and taking their shirts off. So we have to really think through what it means to be a professional. We also have to think seriously about what we're doing. You know, a lot of our ethics is based on Judeo-Christian ethics, and yet we serve populations that, you know, adhere to different faiths. So what about teaching ethics that are based on teachings of Islam, for example? And we find that when we look at teachings around the development of the unborn child, there's a lot of resonance there. You know, by the end of the third 30-day cycle, the breath of life is breathed into the child. And that has huge importance when we discuss in a multi-ethnic group of students issues like termination of pregnancy or prolongation of difficult pregnancies. So we need to really go back and address some of that. But for me, one of the single biggest issues, Jeff, is assessment. Because you can assess professionalism. You know, thank you very much. That's very kind of you. Thank you. You know, to a patient. And I say, gosh, what a nice, polite doctor, you know, and they maintained eye contact, and they did all the right things. Let's pass them. And of course, they get out to the system, to the system, and they default to the behavior that they find within the system. And this is a real challenge for us in medical education, that there's a mismatch between what we tell people and try and encourage people to be when they're in medical school, and when they get out there, things are very different indeed.
Students are not empowered when it comes to what they publish. We have in the booklet a lot of abstract that students published. I'm pretty sure there is no one who walked there to see it, because it's not published in Elsevier or any other of those fancy where professors have to publish to get tenures, to be promoted, to, you know, and that hurts what the student does and why they do what they do. We have, as the Pharmacy Association in Rwanda, the Pharmacy Association or Medical Association in each country has at least a magazine where students do small-scale research in their communities and publish there. But it will never get to act. The Deputy Director of RSSB said, please come help us. Go to your community, ask certain questions. I'm pretty sure there are students who do that, but it never gets its value because they don't think it is worth it because of where it is. It was peer-reviewed by another student, and they think it has to be secretly peer-reviewed by another peer reviewer somewhere because it's Elsevier or something. So I really hope the professors, the chancellors of the university understand the concept of open access to research, open access to the data, and empowering these student magazines, IPSF magazines, where students publish their work, and make sure you tap into those. Open your data to them and say, look at this data. This is what I collected, but this is what I published. Find something else that you think this data can inform and can help. I mean, I'm sorry, but I think I had to say that on behalf of students. Thank you so much.
Deaf people, they're always fighting for their right. But sometimes there are some deaf people who doesn't know their right. And they doesn't know who to do what. Few of them, they might know where they can access the service. We are encouraging them and training them on their right.
And if we define disability as a problem and a medical intervention as the solution, individuals, societies, and governments avoid the responsibility for addressing the barriers that are in the social and physical environment. The social model of disability says that disability is really something that's created by barriers and attitudes of society. It's not necessarily a trait or characteristic inherent in the person with the disability.
Deaf association can't work alone. Let's take an example in Rwanda. We have this association for the student who said RP. Okay, this association, we have some of the members of the association, they come to my office seeking me, please Samuel, we need to teach sign language in our institution. Well, you see, we are in progress to make something. This is how things started. You see, working in a collaboration with all associations, that come to the pushing. If the institution working alone, as the people working alone, we can't reach anywhere. there's a need of collaboration.
I would love to call upon Mr. Munana to sign the word Rwanda for me and inclusive health, the word Rwanda. So Rwanda goes like, audience, let's go. We'll go for inclusive health.
Why are we doing this sign for Rwanda? You know that in Rwanda we are famous gorillas, right? And Musanze, this northern province, you see, everyone when you talk about Rwanda, they understand gorilla. That's why we came up with the sign that referring to what environment of ours in Rwanda.
And the word inclusive health. You put one hand on top of the other. So health, yes, inclusive health. Okay, so thank you to the government of Rwanda for supporting this inclusive health.